Hi, everyone. Can you hear me in the back? Yes, okay, great. Thank you for having me. Today, I will be talking about measuring outcomes in profound autism. Last year, I spoke about biomarker outcomes, and today I'll be talking about clinical outcomes. My disclosures. To disclose, I'm a developer of the Sensory Assessment for Neurodevelopmental Disorders, the SAND, which is a measure that I'll talk about today, and I also consult for Jaguar Gene Therapy and Neuron. All right, so a couple of guiding questions that I will answer, or try to answer, or provide some context for in this talk today. We'll define clinical outcome assessments and endpoints, why they're important for clinical trials broadly, and specifically for profound autism trials. How do we choose what endpoints to use in a trial? What are some of the endpoints that are being used actively in current trials or trials in development? And then when we think about performance outcomes, when we're trying to measure actual behaviors directly from an individual with profound autism, what are some considerations that we can do to try to get the most accurate result? So starting with some definitions. So the way that the FDA defines a clinical outcome assessment, I want you to think about any clinical assessment that a child may be administered or complete, and then think about it as becoming an outcome measure in a trial, something that's going to be measured that if there was change, it would actually reflect how that patient feels, functions, or survives. And a clinical outcome assessment, or a COA, can also be an endpoint, but it doesn't have to be an endpoint. So for example, an endpoint can also be a biomarker. And when the clinical outcome assessment is used as a predetermined endpoint in a trial, that is when we are defining exactly what the variable of interest is, and we're essentially taking a bet on the COA. We're saying we think that this clinical outcome is going to change in this period of time in a statistically significant way. And so you can imagine that there's a lot of complexities in figuring this out. There are a lot of different questions that we want to answer ahead of time, and rigorous planning that goes into determining what clinical outcome assessments are appropriate for the population of interest and the treatment target, and what do we want to select as that primary outcome, for example, secondary and exploratory. And I also want to mention, when clinical trials are first starting, the primary endpoint is always safety, right? We need to make sure that the interventions are safe before we can even really think about efficacy. But simultaneously, we're also trying to look at, in those initial safety trials, are we seeing some signal on these clinical outcomes? So there's 4 different types of COAs as defined by the FDA. We have patient-reported outcomes, where the patient's actually directly reporting about their health condition, which we know in profound autism is not a feasible option. And the FDA discourages proxy report measures, where a caregiver would be reporting on behalf of the patient. So for example, we wouldn't ask a parent to rate how much pain their child's in, right? That would be a very subjective question, but we could ask about specific behaviors, so how often the child was crying, whether they cried in response to a shot, for example, and then you would be looking more at a reported, observer-reported outcome. We also have clinician-reported outcomes, and we'll talk about different examples of each of these later on. A clinician-reported outcome is when the mental health professional is the one who's rating the behaviors observed from the patient and information gathered from a caregiver. An observer-reported outcome is done with the caregiver. So these are in the form of questionnaires or caregiver interviews. And then a performance outcome is when we're measuring tasks directly administered to the patient. So we think about cognitive assessments, language assessments, that would fall into that category. So why are they important? So for over 2 decades now, this sort of challenge in autism clinical trials about the quality of clinical endpoints and the success of our clinical trials, depending on the ability for our outcome measures to demonstrate efficacy, has been circulating. And I think we have made tremendous progress, but the importance of this sort of problem is still there, right? It is so critical that when we're planning trials, we feel confident that the clinical outcome assessments we're using are appropriate for that population and that there is potential for them to change. And we need to make sure that we can expect statistically significant improvement. And so when we think about choosing these endpoints, our primary endpoint is really important. If that fails, we have sort of these backup endpoints that we can look for future trials, but we can't change our mind in the middle of a study, right? These are predetermined variables, so we can't all of a sudden decide that, well, maybe we think that a different COA would be better, that the participants are having a really hard time completing the endpoint. You can't make that change once the trial has been started and approved. So I like this graphic from a paper that talks about what are some questions to ask when the primary outcome fails. And I think these questions are actually really helpful to consider when you're planning the trial and sort of working our way backwards. And so I just sort of highlight here the importance of those primary outcomes. So are the outcomes defined? Are we very clear what we're looking for? And if the primary outcome does fail, what do those secondary outcomes tell us? Do they give us some positive feedback to suggest that, we found something and maybe we need to sort of pivot on what the primary endpoint is for a future trial? So what are some of the complexities? Well, we know that developing new measures takes a lot of years and a lot of people to properly validate. We know that even within profound autism, even within a genetic syndrome, even within a genetic syndrome with individuals with the exact same mutation, there's still variability in the clinical phenotype. And so we need to be able to account for this. And many of the existing assessments weren't developed specifically for profoundly autistic individuals. And so I'll talk at the end about some newer assessments that are really targeting this. But in some ways, it presents a big problem. In other ways, it gives us sort of very specific tools to work with that do fit some of these criteria. So how do we determine endpoints? So the way that the FDA presents this sort of roadmap is first understanding what is the disease or condition, whether it's profound autism, whether it's a specific genetic syndrome, and really thinking about the patient and caregiver perspectives, right? In order for people to enroll their child in a clinical trial, and when I say child, it can be an adult child as well, it needs to matter. That clinical endpoint needs to matter to them. Improvement in these clinical outcomes or what that treatment is targeting has to be clinically relevant. Understanding what's the natural history of the condition, what can we expect over time, and thinking about are there certain subpopulations that this might be targeting more specifically. And then thinking about risks and benefits, what is sort of that concept of interest that you're looking for, and then what type of outcome measure are you going to use? Do you think that a clinician-reported outcome or an observer-reported or performance outcome or some combination of these will be the most appropriate? And you kind of have this, what I would call a relatively small toolbox to look at, and I'll show you some of those. And then determining from that, specifically thinking about these profound autism trials, does the COA exist and can be used as is for this purpose? Do we need to make modifications to that and then show evidence that the modifications are appropriate, or do we need to develop a new COA for this purpose? So natural history data is a valuable starting point. And when we think about natural history data, we're thinking about a broad array of assessments covering multiple different domains, looking at the same patients over time. Now, why is this important? So when we look at cognition, language, motor skills, autism features, sensory reactivity, adaptive behavior, in some cases achievement, we're looking broadly at lots of domains and lots of specific potential clinical outcome assessments. We need to figure out which of these work for the majority of individuals that we're trying to treat. If the scores on a certain assessment are all at the floor, sort of what does that tell us? Or in reverse, if the individuals can't complete these assessments, or they actually have already mastered many of the skills on them, there's a lot of questions that we want to think about and answer. So how do we sort of narrow it down? So we want to first think about what's the treatment target, and which of these domains are worth looking at, or do we think are relevant? We need to think about what intervals of time will we collect this data. Do we think in a 12-week trial, for example, that this COA has the potential to move? Or do we need to extend the length of data collection or choose a different outcome? We really have to expect that in that period of time, change is possible. And is it feasible for all patients? If no, then we need to stratify, and we need to determine sort of what are the cutoff scores for eligibility. What will the inclusion criteria be? And I think a lot about if you're choosing, let's just say, a scale on a caregiver questionnaire, and a caregiver doesn't endorse this as a problem for their child at all, well, then there's no room to improve, right? So we really need to be thoughtful up front about if we're choosing endpoints, what's sort of the minimum criteria necessary to ensure there's room for improvement. All right, so now I'm going to jump into some COAs that are being used in current trials. And coming back, I just wanted to mention here that clinicaltrials.gov has the outcome measures for every single trial listed for it. So if anyone's ever curious, you can always look it up. This is just an example from our ketamine trial in ADMP syndrome, and you can see this was the first study. The primary outcome was all safety, and then we had additional secondary outcomes, and it even tells you what the time frame is that they'll be looking at. It tells you about the measure, so there's a lot of information that's accessible to the public that I would encourage you to look at if you're interested. So now coming back to this slide, I'm going to talk about a clinician-reported outcome, the CGI, and some newer, more specific versions that are in development and that are being used actively in trials. I'll talk about 2 observer report outcomes, so the Vineland Adaptive Behavior Scales, which is a clinician-administered interview to the caregiver that asks about adaptive behavior across socialization, communication, daily living skills, motor skills, maladaptive behavior domains. And then I'll talk about the ABC, which is a caregiver questionnaire. I'll talk about the SAND, which combines both observer report and a performance outcome. And while I won't talk about the additional performance outcomes, I will talk at the end about special considerations for cognitive, developmental, and other performance outcomes. So this is just a standard CGI. The CGI is completed by the physician or clinician, and it provides a global impression. So the nice thing about the CGI is we're not looking necessarily at just one particular domain, such as communication. We're looking broadly overall. We get this global rating, and there's a severity measure. So how severe is this child, for example, based on other individuals with profound autism, and that is the decision what you're comparing to. That would be done in the planning phases. And then the CGI the improvement measure, which would be done at critical time points. Now, in order and in an effort to, I think, make trials, multi-site trials, more reliable across sites, and to really sort of streamline the CGI and standardize it as much as possible, several groups have made CGIs that are specific to certain genetic syndromes. And while I'll use these as examples, I am really optimistic that the more of these that are created and being created, we're seeing a lot of overlap. And that's because of sort of the nature of profound autism, that I do think this is really going to be relevant for trials well beyond just these specific syndromes of interest. So Phelan-McDermott syndrome and Angelman syndrome are 2 examples where syndrome-specific CGIs are already developed, being used in trials. The first step of that has happened in ADMP syndrome. We're currently working on this at the Seaver Center in FOXP1 syndrome. And that first step is really figuring out what are the most clinically meaningful symptom domains. So leveraging that feedback from patient advocacy groups, families, the natural history data, and all of the information taken together, what domains are of interest, and then how can we create very clear anchors for each symptom domain so that a rater across various sites can rate the same feature in the same way. And then figuring out what is clinically meaningful change, what does that look like, and what does that look like in this syndrome, and that is where some of the natural history data can be very helpful, understanding sort of what is the expected rate of growth on these various measures over time. All right, and then just to sort of highlight something that's really nice about the way that the PMS group did it, you see their CGI-I and CGI-S include symptoms that are relevant to all individuals to some degree who have PMS. So expressive and receptive language, fine and gross motor skills, social interaction, cognition and learning, self-care skills, and then separated that from symptoms that are highly impactful but only relevant to a subgroup. So seizures, for example, GI symptoms, sleep, and so this really informs sort of how these measures can be used in trials. And then using the Angelman example, thinking about the very specific way that they're anchoring their each domain. So for example, in expressive language, it breaks it down based on the number of words. Receptive language, are they understanding any language? One-step instructions, two-step, three-step, and all of those would actually be rated differently and very consistently across raters. All right, I'm going to turn to the SAND, which is, I'm biased, but my favorite. So the SAND is a clinician-administered observation along with the child, or the patient in the case of a clinical trial, along with a interview with the caregiver. Everything that we're rating as a clinician is then being asked in interview form to the caregiver. We're looking at sensory hyperreactivity, hyporeactivity, and seeking behaviors across visual, tactile, and auditory domains. The sort of domains were chosen based on DSM-5 criteria, and then those modalities were chosen based on things that we could measure in individuals of all levels of ability. There's no prerequisite cognitive or language skills necessary. We were able to develop this really by learning a lot from the clinical trials that we had done at the center and thinking about the challenges of, for example, comparing IQ scores to a developmental assessment, so to developmental quotients, for example, thinking about measures where there were different norms for different ages. And so this is a measure that can be used continuously. It's normed for individuals 2 to 12, but is appropriate for individuals with developmental ages below 12 years old and below 2 years old. All right, and we were fortunate in terms of the data showing that there were no age effects. So we are able to use a continuous variable across ages. This is a replication of what's in the manual with more recent data where we really see across the scales there is not an impact of age. And just so you get a sense of structure, you have the total score that combines the observation and the interview, and all scores combine the observation and interview. So I like to think about it, anything that we see on an observation in a 10-minute observation with a child is likely impacting that individual within their everyday life. But there are many sensory differences that we wouldn't necessarily see in those 10 minutes with these specific stimuli, and that's where the addition of the parent interview is really important. So when we're thinking about, okay, if we were to use the SAND as a COA, this, as with all of the measures I'm going to show you, there's a lot of questions, right? Do we go with total score? Does this syndrome show a specific sensory phenotype, for example, that we would want to explore more broadly or think about maybe as an endpoint that's even more specific? So I'm going to show you some video examples of what we would call sensory seeking behavior in individuals who have the same genetic syndrome. And here you're going to see you're going to see across visual, tactile, and auditory domains, sensory-seeking behaviors. So you're going to see auditory seeking, you're going to see tactile seeking, and auditory seeking. You're going to see more tactile seeking, including the chewy, plus visual seeking. And then here you're going to see tactile and visual seeking, so rubbing the shirt, and you'll see some visual inspection of the object. So here's one clear example where you can see different kids showing a similar sensory phenotype that you could imagine in the context of a clinical trial. You could pretty objectively demonstrate change, and that would have a profound impact on their everyday life. You could imagine when you see this in sort of a 10-minute observation, how that can really impact being able to sit and learn a task or attend or socialize. So we've now described in several papers the sensory phenotypes of different syndromes. Here I'm just giving two examples where they've then been applied in clinical trials. So here we have on the left the SAND and the ADMP syndrome trial. This is open label, so we do need to continue looking at this, but we did see significant improvement in sensory reactivity across each of the time points post-infusion. And then in this pilot study where we looked at the last 10 participants in the IGF-1 trial that was done years ago here at the Seaver Center, we saw a significant improvement in total score, and that was driven largely by improvement in hyporeactivity, which we've described is a very significant feature of Phelan-McDermott syndrome, very high thresholds, very under-responsive across modalities. So turning to the Vineland, here's an example of an individual with profound autism at 5 and 15. And the sort of complexity or the point I want to show here is where we're not only picking the domain, but we also have to pick what type of score do we want to look at. And so, when we're providing reports to families, we're showing standard scores. This is what schools know how to interpret, and this is what provides access to services. But as you'll see, standard scores we know, as the gap gets wider and kids get older, the standard scores are always going to decline. And so you'll see the floor here is 20. But when you actually look at the raw scores, in several cases, the raw scores aren't going down, they're going up, right? And so our standard scores can't capture that. I think about if you look at the community domain and the domestic domain at 5, a raw score of 0 gets you a higher score than, for example, a raw score of 0 on domestic or 10 on community at 15, right? And so if you were looking at that standardized value, you would actually think the scores went down, but in reality, they didn't. And so raw scores can be meaningful. There's also the growth scale values that have attracted a lot of interest that sort of account for this natural decline with standard scores. And then the aberrant behavior checklist, the ABC, just so you have a sense of what it looks like. A caregiver fills out a form that asks a variety of questions that fall into these 5 domains, and a parent rates it. Is it not a problem at all? Essentially a mild problem, moderate problem, a severe problem. And each of these items falls within a domain. So irritability, social withdrawal, or lethargy, they originally called it, hyperactivity, stereotypy, and inappropriate speech. So again, for a given trial, you can predetermine, well, this is the scale that we think is going to move, and we know that the ABC is appropriate for the profoundly autistic population. Now, all of these have pros and cons. So the ABC, we also have to think about sort of the scale in terms of what is the range of possible scores, which can be small. And we also have to make sure that if we're picking a specific domain of interest, anyone enrolling in that trial actually is showing concerning behaviors in that area to make sure there's room for improvement. All right, so what special considerations do we want to think about when we are trying to obtain cognitive, language, and other scores directly from the individual with profound autism? So our goal is to obtain the most accurate measurement of an individual's abilities possible. And I want to remind everyone, especially the parents in the room who come and are so patient through all of the assessments that we put all these kids through is that it feels hard because it is hard. We're not measuring things that they've mastered, or we wouldn't be enrolling them in a trial, right? So we're trying to pick what are these domains that we can measure objectively where we can see improvement that will be meaningful. So a couple considerations that we really like to think about. When I think about families coming through our center, we have always prided ourselves on being able to test the untestable kids. The number of parents who have come to us or given us reports where it says the assessment couldn't be completed, we can get standardized scores on every child who walks in. Doesn't mean we can get it the second they walk in the first time. No, not always. But here's some sort of tips and recipes to be able to make sure that we can get this data on these kids. Oops, sorry, going back. All right, so first we want to make sure that the tasks or questions are appropriate for the participant's skill level. So I said it will be hard, but they'll be able to do some of it, right? We need to make sure that we're choosing assessments that are appropriate for this population where we think there can be improvement. We want to determine whether time constraints are necessary. On certain assessments they are, but on certain they're not. Sometimes it's simply to sort of give suggested guidelines for the flow of the assessment. And if I want to know if a child's improving, let's just say their receptive language, and it takes them an extra 10 seconds to point to the object that I'm asking about because of their motor skill delays, right? I'm not measuring their motor skills. So we really want to be cautious that we're not sort of losing potential efficacy because of some of the rigidities of the sort of initial instructions or the standardized way that we think about these assessments. We also want to make sure that there's opportunities for breaks, flexibility in schedules. We have families come for multi-day visits, because while we could cram it all in as much as possible, we want to make sure if a child doesn't sleep well, if a child's not feeling well, many families are traveling long distances to come for these trials, that we have that flexibility to adjust, to pivot, to do something, finish something the next day, and move things around. And then finally, considering sensory aspects of the environment. So, what does a child benefit from to satisfy their sensory cravings? Is there a child who, benefits from having a chewy or something in their mouth? If we're not giving a language assessment, we want to make sure that they have that. We want to make sure that we're getting the most accurate picture possible. If the child's being distracted by the lights, how can we think about modifications we can make in the environment? How can we use visual supports that we know work to show and tell the child what to expect, what's expected of them, what's coming next? We all benefit from these things. We know that they work, and they don't invalidate assessments by integrating some of these behavioral support strategies. All right, and then the FDA even has guidance on these modifications. So things like changes in the instructions, omitting, adding, or modifying wording. So you can imagine maybe there's a scale that is pretty appropriate, but there's one or two items that don't apply to anyone, and you have that information, for example, from phenotyping or natural history data, there's flexibility there. Again, has to be done ahead of time, has to be done consistently at all time points, but these are decisions that can be made and proposed. Adjusting the order of items. You have a kid who's maybe very active and walking around the room. Why not start with the gross motor section and then come back to the table work? What's the recall period of time? The format, so paper versus electronic, and then changes in scoring. These are all things that can be considered. And I just want to give these examples that while we want to make sure that any adaptations are offered consistently, some manuals even have information that lets us know whether modifications can be made and standard scores still can be used. For example, the Peabody Picture Vocabulary Test, which is a measure of receptive language, in the manual specifically says that you can allow extra time for responses and still the standard scores are valid. There's also information that was provided for a clinical trial on autism years ago where there was a motor task and only one side of the task was needed. Pegs have to be put into a board, the Purdue peg board, and they covered one side of it to sort of simplify the task. And while it did invalidate the norms, it allowed for objective motor data to be collected. All right, so just ending with a few key takeaways and future directions. So one, I truly believe that profoundly autistic individuals can make significant improvements. I think that the sort of landscape of clinical trials now is the most exciting that it's ever been, and that with the right COAs, we will be able to capture improvement. I also want to just show this figure from that Lancet article that Joe mentioned. And I really think this is so important to think about, not just a clinical trials perspective, but when you look at the purple, that profound autism group, what you see is sort of the improvement in adaptive functioning that comes with greater support, greater recognition, greater adaptation to society. And so I think for all of us to really think about this, that there is room for growth through clinical trials, plus all of these other things can really make a difference. And we know that adaptive functioning is a huge predictor in quality of life for families and individuals. And then finally, to offer some more hope, there are a number of COAs that are in development that are being applied in clinical trials now and in natural history studies. So the ORCA, the DASCA, the PNI, which was developed by Dr. Feik in our group, the BOSC. So I think, thinking about while our toolbox is small, it is growing, and there is a lot to be optimistic about. So with that, a huge thank you to all of our participants, their families, our funders, and to my team who allows me to do this amazing work every day. Thank you.